repairs get the most attention because they're the most difficult to perform and also give us some of the most challenging problems after surgery with rehabilitation, and we often have gapping or rupture in this area, and most commonly we have stiffness. It's hard for us to get a great result when tendons repaired in this area and restore all the motion of the MP joint and the PIP joint. So this area is called Zone 2. It goes from halfway up the middle phalanx. This is the insertion of the FDS tendon to the A1 pulley. This area was named no man's land by Dr. Sterling Bunnell, kind of a father of modern hand surgery, and he used this term in one of his early textbooks. And again, here is Zone 2 from the A1 pulley to the insertion of the FDS. So this area is challenging because it has lots of fibroosseous tunnels. So you have A1 pulley, A2 pulley, you have your cruciate pulleys, and the caliber of these pulleys is very narrow, and the tendon occupies the entire space. In fact, there's 2 tendons here, so a laceration in this area is technically very difficult to repair. I see a lot of our billers and coders here. I think everyone knows that the CPT code is actually different for when we perform tendon repairs in this area versus in other areas, and there's a slightly higher reimbursement for doing so because it's a lot more frustration and work on our part. Okay, so no man's land is a term from World War I on disputed territories between 2 warring sides to describe an area where nobody really wants to deal with. So I think that's why they named Zone 2 after this area. For many years, up until maybe the 70s, surgeons did not have good results when they repaired flexor tendons in this zone. And the thinking was that whenever they attempted or they tried to repair flexor tendons, they just never got a good result. And so a lot of surgeons at that time simply abandoned doing flexor tendon repairs in that zone when they were, of course, primary repairs. They would always, even if you got a flexor tendon repair that was like 2 days old, you wouldn't attempt to primarily repair it. You would actually put a hunter rod in if you were, in that time period in the 60s, 70s. And that was the thinking of that time. There was a meeting in the late 60s, American Society of Hand Surgery, where Dr. Harold Kleiner reported and presented his results, and his group's results, on primarily repairing flexor tendons. And he was able to show that 87% of them actually did have good results when you repaired them primarily. And apparently a lot of the other hand surgeons in the audience did not believe him, because none of them were doing that, and they'd never heard of doing that in recent times. So they actually, because they didn't believe him, they had a site visit to his hospital center, and many hand surgeons actually came to visit, and they did their own private investigative type of review of all the patient charts to verify that primary repair of flexor tendons was actually yielding good results. And simultaneously, many of the protocols that were in use for a long period of time, I think some people use variations of it, but the Kleiner rehabilitation protocol was also very good and instrumental in the success of these primary repairs of flexor tendons. So around this time, it became more popular to start repairing flexor tendons primarily. And that's thankfully what we do now. The surgeon can approach the flexor tendons through various incisions based on their preference. There's a difference if somebody cuts their tendon in flexion, like if you're holding a knife for some reason, like this, because then if you're in flexion, all this tendon is on stretch. So now when you're in extension, if you open the surgical site at the location of the cut, you won't see the tendon there. And it's really frustrating because it's all the way up there. So it's kind of a challenge to reroute it back together. This scenario is a little bit easier because here, when you're near the surgical site, the two tendons are at a more favorable distance. These are different surgical exposures of how we approach these. And this is important because we're always trying to be strategic in our surgical exposure so we don't violate the A4 pulley and the A2 pulley. These two pulleys are very strong and they contribute to biomechanical strength of the tendon. And if we didn't have those, our tendons would just be very floppy and they wouldn't generate the force and momentum needed to actually bend our finger. Studies have shown that you can actually release up to half of some critical pulleys without too much of a consequence. And sometimes this is necessary. I think we talked about the surgeon in Canada who's doing wide awake surgery and directly visualizing a person flexing and extending during surgery, and you can release as many pulleys or parts of pulleys as you need to make sure that happens. And the studies have shown that rotation or weakness after you release the pulleys occurs after 50%. So based on this, no matter where the laceration is, you can be cut here, 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 even like within the most critical pulley, you should theoretically be able to get a repair by only releasing, say, half of your pulley at any one time. And this is just something you have to do in surgery. You have to position your tendon either by flexing the finger or by putting tension on the proximal end and bringing your two tendon ends together in a way where you're not cutting open all of these things. It's pretty challenging, but sometimes very frustrating. These are, because of that, because it's so frustrating, there's all these tools and devices and techniques invented to almost thread this needle through, or thread this string through a very narrow needle, essentially. I tried variations of all of these. I usually do this first, and if I don't get it on the first try, then what I do is I cut proximally, and I find the tendon there, and I force feed it up towards the site of the actual cut. And that's worked out pretty well for me. So once you actually put the two ends of the tendon together, how do you fix them? There are so many different techniques and patterns. This is a pattern I like to use for a zone 1 tendon repair. And any of these are actually acceptable for the zone 2 tendon repair. I like using this one, but the key is, and Rob mentioned this in his talk earlier, I think all of the therapists here are very interested in our operative reports after tendon repairs because they're looking to see how many strands of suture we use and also the caliber of suture that we use to really ensure that we're performing a strong repair. I would say standard is at least 4 strands. And this is a 4-stranded technique, 6-stranded technique. This one's a really good one too. And studies have shown over and over again that the increasing number of strands that cross the repair site lead to increased strength. Now at some point, sure, you can sit there and put like 20 strands of suture across the tendon, but then you're obliterating all the surface area of cells that can really adhere to each other and heal. And it's just a pain and it's cumbersome to do that. So I would say most popular is 4 or 6-stranded repair techniques. And then this is again the one I like to use. Some studies have shown that that technique was slightly stronger than others, but these aren't very high-powered studies, so I think it's important that the surgeon use whatever technique they feel comfortable with and they've had a good result with in the past and have yielded good results. So I think there's no one accepted technique or superior technique, it's just the one that works best for you. But at least it should be 4 strands. And then in the zone 2, an epitendinous suture has also been shown to add stability and strength to the repair, and it also smooths the ends of the repair, allowing the bulky tendon repair site to go in and out of the pulleys easier. And studies have shown that you should make your epitendinous stitch at least 2 to 3 millimeters of purchase of the tendon. And again, this is also cumbersome to do, which is, I think why zone 2 tendon repairs are reimbursed slightly higher. This all adds time, whereas I don't do epitendinous repair and say more proximal than zone 2 repair. What type of sutures should you use? Studies have shown that the increasing size of the suture leads to increased strength of the repair. But at some point, so why aren't we using like what the orthopedic surgeon uses, which is a number 2 fibrocord suture? It looks like a big piece of rope. Well, again, that obliterates the surface area that the 2 tendon edges have in healing each other, and it also creates more work of movement. So these, in my opinion, are the most popularly accepted suture types. So again, I think the therapists really do read our operative reports and make sure that we're using a nice, strong suture. And Ethibond, Merceline, Tycron, Fibrowire are all good, and Supermid is another one. Those are all, I think, acceptable options. And again, we're looking for 4-strand or higher repair. I'm using 3-0 suture, possibly 4-0 as well. In zone 2, there's also a technique and it's good to make sure this is documented well. Well, do you repair both tendons or just one? I personally have taken more and more to repairing just the one, just the profundus tendon, because it gives the most movement. It's going to move your DIP joint as well. And whenever depending on the location of how the FDS was cut, it usually just gets in the way, I found. And it adds a lot of bulk and volume, and you have poor range of motion afterwards. So I found that I've just been increasingly just resecting the FDS. And after that, it's really, we say a prayer, we close up, we put on a splint, and it's the occupational therapists that do all the work after this type of surgery is done. And, patients are really frustrated with these tendon injuries because they'll be slicing an avocado and it's like a cut this big, and they're like, wait, I'm out of work 3 months now. It's incredible how something so small and innocuous looking at first can really take somebody out of work for that long, and take many man-hours on the part of them and the surgeon and the therapist to get them a functional result. But that's just a summary of flexor tendon repairs. I have no other disclosures. And thank you to Dr. Kleiner, that's where I did my fellowship, and his references.